Many of the attacks for HAE patients stem from either a stressor or an inflammatory process. So inflammation such as injury, dental work, and so on. Emotions can play a role, any kind of other sickness, and so on. But typically a patient will have some sort of prodrome or knowledge that an attack is about to start. Now, sometimes you may not have such a warning signal, but oftentimes you'll hear patients say that that's the sort of warning that you get beforehand. I think primary care physicians need to have a higher awareness of HAE so that they can diagnose it more properly and then send them to get referred to a specialist, such as some of us who are allergists, immunologists, so that the patient can have a shorter time from the onset of symptoms to getting proper treatment. Some of the specialties that need to get a higher awareness of HAE would include gastroenterology, because if you think about it, a lot of the attacks will involve the abdominal area. Emergency room physicians, obviously, because they'll see a lot of these swelling attacks in peripheral areas that may mimic allergies and may get misdiagnosed as that. Dermatologists may see some of these as skin inflammation and so on and need to have that heightened awareness. Obstetrician gynecologists can have some of their patients complain of abdominal aches and get a workup that includes a negative uterine, ovarian, and so on workup with a persistent complaint of abdominal pain. And at that time, no matter who the specialist is, they should really think about, especially if the treatment's not working, for a differently thought of diagnosis, than to throw some of these labs into the equation and try to figure out what is going on with the patient. If the patient's lucky, they'll see that first physician that diagnoses this correctly, but it's not unusual to have gone through even up to a double-digit number of physicians to get the proper diagnosis. And it can be quite frustrating if you listen to some of these patients who go down that route. We're actually working on increasing the awareness for the physician and allied healthcare practitioners by including and increasing the number of continuing medical education credits that involve HAE as a topic. Going back to the medical schools, now that we have treatments, the professors are going to be more excited to teach a condition that has basically A to Z, from diagnosis to treatment. Definitely there's a gap there in the publication arena where we're looking at the whole condition. I mean, there's a lot of excitement around this topic. We have a condition that's very straightforward. It's autosomal dominant. So once you've identified a patient, technically you're going to look above or below them intergenerationally to diagnose potential other relatives. We need a unified guideline. I think there are two ways of cutting this. On one hand, having multiple guidelines from different groups represent those geographic, if not patterns of thought areas where one guideline may not be as applicable to a specific group as another one might. The advantage of having one unified guideline would be to have any physician sort of look up on the internet and access that particular set of suggestions, recommendations, and go by those set forth rules in order to provide the best health care delivery to the patient.